Cancer. Been talking about lung cancer and different aspects of lung cancer. Today, we talk about the myths and facts around lung cancer. So, there are common perceptions on lung cancer, and we will talk to our experts to understand whether these are actually facts or they are myths. We are very privileged to have with us Dr. Naresh Somani, who's MD/DM Director and HOD Medical Oncology at HCG Cancer Center in Jaipur, and Dr. Vidya MN, Lead Consultant, Department of Pathology in Manipal Hospitals, Bangalore. And let's understand, from them as to what are myths and facts so that we are able to make better choices and treat our lung cancer better. In the past, we've done, as part of the series, we've done 2 previous discussions. We've had a panel discussion, which included a patient advocate, Mr. Vivek Tomar, along with Dr. Sevanti Limay and Dr. Rekha Pai, where we talked of the barriers and the advances in early detection. And we've also spoken to, We've also spoken to Mr. Ravi Prakash, again, a patient advocate, along with Dr. Thomas Alex and Dr. Amit Rothan, on the progress in lung cancer. And you can find these on our YouTube channels or our Facebook page if you've missed it. So a quick reminder to our audience, Patients Engage is an online platform for patients dealing with chronic diseases and for them and their caregivers to share personal experiences. So we always welcome people to reach out to us if they have something valuable to share. They can also learn from each other, from healthcare professionals, and the better informed they are, the better choices they will make, the better they can navigate complex diseases like lung cancer. And as we always say that, people should not have to deal with any of these complex conditions on their own. This webinar is sponsored by Roche, and the views expressed in this video are of the speaker and are meant for spreading general awareness. They do not necessarily reflect those of the publisher or the sponsor, which is like neither us nor Roche. And most importantly, the information does not replace a medical consultation. So please do discuss with your doctor, or you can reach out to our panelists directly for specific medical consultations. And as always, you can contact us through our social media channels, as well as you can write to us at editor@patientsengage.com or check out our website, www.patientsengage.com. So with that, let me get started. Thank you, Dr. Somani and Dr. Vidya, for joining us in the middle of a busy day to talk to and educate our viewers. Today we will talk about some of the common statements that we hear around lung cancer and what people typically talk about, and we just want to understand from each of you as to what whether these are myths or facts. Is lung cancer a chronic cough? People often think of it as chronic and then they think it will go away eventually. So is that a myth? Is that a fact? Dr. Somani, if you can start.
Yeah, good afternoon, ma'am, and good afternoon and warm regards to everyone who is so very being connected with us. So there are so many myths being attached to cancer, and like any other cancer, lung cancer is not away from that. So any symptoms like chronic cough or blood tinged sputum or little bit chest pain or dyspnea, if it persists beyond 2 to 3 weeks, that means some pathology, some organic cause for that is there. That is not functional. That is not simply like seasonal variation or change of the weather or something like that. So we need to investigate now, especially the people above 40 years of the age, those who are having like the history of the chronic smoking or excess of smoking. They should keep in the mind that this may be one of the symptoms for the development of the lung cancer. So the persistence of the cough, even if it is a mild dry cough, it should not be ignored. And if it is being associated with the dyspnea, breathlessness, chest pain, or some history of the blood in the sputum, or anything like the weight loss or hoarseness of the voice, change in the voice, or any other symptoms in the part of the body, it should not be ignored at all and should go forward to the clinic or to the concerned doctor and get it investigated.
Right. Thank you. And when you get it investigated, at what point should you be, and this is to either of you, I think, at one point, because sometimes we've found that they've gone to a doctor and it's got treated as either, uh, a normal cough or a pollution allergy, etc., and that causes delay in the diagnosis. So at what point should they be, kind of maybe more suspicious and say that maybe it's more than that, and I should be getting this investigated through another specialist, or I should seek a referral.
So as I just said, that the symptoms are persisting, associated with the weight loss, blood in the sputum, other respiratory symptoms like chest pain, breathlessness, hoarseness of voice, definitely it should be a matter of the concern. And we should go to the respiratory doctor or to some other physician doctor for the primary checkup. Now, if X-ray chest, which is done routinely, often in the outdoor clinic base, if that is showing some pads, some nodules, something suspicious, then CT scan should be done. Now there are the concept of the low dose CT scan for the screening also, where there is a minimum hazard, radiation hazard, and it can be done especially in the smoker or the high risk patients.
Right. Thank you. Dr. Vidya, one of the things that has traditionally been a viewpoint that lung cancer happens only to smokers. Is that correct or not?
Definitely not. It's actually a myth that only smokers get lung cancer. Over the last few decades, we have seen that there is an increase in incidence of lung cancer in non-smokers. This is especially so in women. So that could be due to passive smoking, what we say, or call it as secondary smoking, then due to air pollution and indoor pollution, like it could be due to wood fuel or coal tar burning, etc. So these are instances where we are seeing an incidence of rise in lung cancer in non-smokers. So it is not just limited to smoking alone. Smoking earlier and even now, it is the leading cause of lung cancer. But non-smokers, we are seeing and coming across multiple age groups of cancers related to these patients.
Right, right. The corollary to that we sometimes hear is, when we, as part of our awareness activities, when we tell smokers to quit smoking, they often say there is no point in quitting smoking now, right? I've already been smoking for 10 years, 20 years. So if it's a risk that is there, why should I quit? So, what's again, is that something that they are right or they're wrong? Uh, Dr. Somani?
Yeah, they can't be right. There is
Mm,
always misuse of tobacco or smoking, cannot be any use. Now, as the years or the number of the packs of the smoke increases, the chances of developing not only the cancer, heart disease, asthma, COPD, brain damage, everything, every part of the body is being affected by the smoking or tobacco for that matter. So it's always a myth that I have taken it for 10 years or maybe more, 20 years, and now there is no point. Now, the moment you stop, within 24 hours, your heart rate starts settling down. Your risk of developing the coronary artery disease or the heart disease and the brain attacks, which we popularly say the brain attack, their risk starts decreasing.
mm,
So it is always beneficial to stop it, and the benefits start coming very soon, and they keep persisting. And second thing, we should not forget that the risk because of the excess and the prolonged smoking does not become zero. So
mm,
it is not that let me smoke first 20 years and then I will stop it for some time.
right,
And I
right.
will become normal or near normal like any other person in the next 1 month or so. No, it never
Mm,
becomes zero. So it's always better that we smoking earliest possible and in totality. There is no concept like low smoking or low tar smoking or so-called female type of the cigarettes, this and that. No.
Right. Right.
I would like just to add a point
Sure.
here.
Sure.
Smoking not only causes lung cancer, it can cause various other cancers as well. It has been the etiologic factor in 15 other cancers like your gastrointestinal cancers, pancreatic, bladder cancers, etc. So the person should be aware that it is not just about the lung we are talking. And like Dr. Somnani just now mentioned, it could affect the heart, the liver, the
Mm.
lung, anything. So here the patient has to be aware and they should take it with a good reasoning that, look here, this is going to be dangerous for my health,
Right.
even otherwise. So, and then quit smoking.
Right. So again, what we are now seeing, especially among the young, an increase in the e-cigarettes or vaping. And there is this, again, belief that it's low tar or no tar, and therefore it does not cause lung cancer. Dr. Vidya?
Regarding vaping, there are no direct evidences it being linked to lung cancer. Vaping is something that we are seeing over the last few years or so, and generally we know that lung cancer occurs after many, many years after
Mm.
exposure to the toxic, right? So maybe we will require and need to analyze over the next few years, like whether there are some instances of lung diseases or lung cancers coming up in these patients. This will require a lot of study period, and the duration, maybe next few years, is something that we need to be watchful about vaping as a process here.
Right. Right.
One thing I would like to add here is that these are the first steps, vaping or low tar or like electrics, this or first step towards the addiction. And
Mm.
ultimately, maximum of them land with the tobacco or smoking or the nicotine smoking. So ultimately, they become addicted, and that again is the harmful.
Right. Right. And Dr. Somani, do you also find that when people come to you and they've got a diagnosis of lung cancer, they then say that, okay, I'm already diagnosed with cancer. Why should I quit now?
So yeah, that happens, and even when the treatment is completed, they often go back in the smoking. That's very disturbing. But let me make it clear through this today's discussion that while active anti-cancer treatment, chemotherapy, the one is doing is smoking, there are inferior or the poor results of the treatment.
Hmm.
Outcome remains poor. And if the one is smoking and there is a possibility of doing surgery, then again chances of complications they do increase. So it's again a myth that once it is done, let me take the treatment. What does it make any difference whether I smoke or I don't smoke? No, it makes difference. If you stop it, your chances of recovery, chances of the outcome with the chemotherapy, combination chemotherapy, that improves a little bit.
Right. Right. I think that's an important one because people don't think of it as affecting the course of treatment or the outcomes, of the treatment. So I think that's an important point. Uh, Dr. Vidya, these days, because of the increase in air pollution, especially in the bigger cities, I know you talked of air pollution due to, those old style cooking gas stoves, etc. But even now, due to air pollution, there is talk of whether, that air pollution is causing lung cancer. Is there evidence to that? Is that a myth? Where are we on that?
It's definitely not a myth here. Air
Mm.
pollution definitely has its toxic effects, and there have been direct relation with lung cancer as well. So any sort of pollution which is going to accumulate these carbon particles, and it is going to be a long-term exposure, definitely is going to elicit a lot of inflammation within the area of the lung, etc. That's what we call, and then hence lead to cancer. So there is a direct implication with air pollution, and especially so in our tier one cities where we are chronically exposed to air pollution. So this is where we look at it. But if we take our rural scenario, it is going to be different. It is going to be the indoor pollutants, like how I mentioned. So definitely this is a leading cause of lung cancer now. If you see people who do not smoke, why
Mm.
is there an incidence of increase in lung cancer? So it can be directly attributable to the level of pollutions that we are seeing these days. Recently, New Delhi had been in the news, right, for so much of pollution over there. So these are instances where the urban population has to be really careful on how they get exposed and what precautionary measures they take. And as such, I would say that there has to be community participation in bringing down the air pollution levels. That is where we are heading to.
Yeah, but because I think there is very little that as individuals they can do to protect themselves in these, the high levels of pollution. We really do need to make kind of strong policy and, kind of very the state and the citizens, etc., will all have to come together to really fix this problem long term. And it's not just Delhi; it's starting to affect a lot of cities as well, both tier 1 and tier 2. So I think that's really concerning. Anything that you'd like to add to that, Dr. Somani?
The problem is not limited nowadays to metro or level even two. It's now even affecting the industrial townships also, and even tier three cities, small towns, because everyone now is having the measurement of these indices. So we keep reading in the local papers also that even the small towns, district headquarters, they are having the bad pollution. And the disturbing aspect in that is that these populations are the non-smoker,
Correct.
and they are the relatively younger age group. And Dr. Vidya will agree with me that most of the time these are the adenocarcinoma type of the lung cancer rather than smoking related cancer, which are squamous cell cancer or small cell type of the lung cancer.
Yes, sir, definitely. So the adenocarcinomas are very commonly seen in non-smokers, whereas the histological type of squamous cell is attributed most commonly to smoking. So these days we are seeing this incidence, and especially so in the female population. So it has suddenly risen. So that is what we are able to make out. And also the earlier it used to be the older age group, but whereas when we see the incidence now, it is very young people who are being affected with lung adenocarcinomas.
Right. Yeah. So those were the two other, comments we typically used to get, is that because there is this perception that only men get lung cancer, or, lung cancer happens after the age of 60, there is often not enough awareness or alertness around lung cancer. So, if I know you both just talked about it, but if you can talk us through, Dr. Vidya, on the types of lung cancer. I know you said there's adenocarcinoma and squamous cell, but then there's also this term used for small cell and non-small cell. So if you can kind of, is that like a matrix of 2 by 2, or how does that actually, and how would you explain it to a layperson?
Yeah, for a layperson, or when there is a lung cancer that is being detected, the pathologist generally reports or comments on telling whether it is a non-small cell carcinoma or whether it is a small cell carcinoma. This we can take as two broad classifications because the treatment aspects, the molecular mutations are different in both these cases. So the driver pathways are different in small cell versus non-small cell. And two, the medical oncologist, when the pathologist is going to put the report as non-small cell lung carcinoma, they know exactly what is the next steps to be taken when compared to small cell carcinoma. Small cell carcinomas, definitely the percentage of cases are less when compared to non-small cell lung carcinoma. And in non-small cell lung carcinoma, when we broadly define them into further histological subtypes. That includes adenocarcinoma, which is the most common, and then comes the squamous cell carcinoma. Then we have large cell carcinomas, and then various other varieties under them like sarcomatoid carcinoma, etc.
Right.
So here when we see adenocarcinomas, generally that forms a bulk of what we diagnose on a day-to-day basis. So here they have various mutations and different targeted treatment as well. So squamous cell behaves in a slightly different fashion, and here squamous cell carcinomas earlier and even now are associated to smoking, whereas adenocarcinoma is generally associated with non-smokers. That is what we see. And also when we come to small cell lung carcinoma, here generally they have some neuroendocrine markers that we put up for these diagnosis of these cases. And here again, they are related to history of smoking. So when we analyze our records over the period of 10, 15 years, now the most common type is NSCLC, or what we call as non-small cell lung cancer. and over there about 50 to 60% of the cases are adenocarcinomas. So these are the broad histological types that we define. And why should we differentiate this? This is because later, whatever the precision diagnosis that is required and the precision therapeutics that is required for these cases are going to be different. And then the patient can undergo the particular type of tests that are advocated for each of these lung cancers, and there begins their treatment pathways. Without this classification, I don't think it is possible for the medical oncologists to designate a particular type of treatment to the lung cancer.
Right, right. And which is why there are these series of tests for the process of diagnosis, right? So, because sometimes patients don't understand why there are these various steps and why the treatment is not starting. So I think that's Dr. Somani, would you want to add to what Dr.
No,
Vidya said?
just to reiterate that in lung cancer, especially the non-small cell lung cancer nowadays, the molecular test based on the NGS type of the platforms or the methodology, that is very, very important. The message which I want to give through this today's discussion is that we should pay the attention. It should be counseled properly. The patient and the family need to understand it. That based on the CT scan, PET CT scan, or the biopsy report, we are probably halfway only to achieve the best understanding about the treatment algorithm or methodology. Until we understand the PDL1 test, the molecular actionable mutation, the test for the predictability for the immunotherapy drugs, probably it is not the right way, especially in the advanced type of the lung cancer. Not only in the advanced cancer, nowadays we talk about the test in the stage 2 and 3 lung cancer also. So it is the crux of the story that always whenever there is a lung cancer being diagnosed, we should go for the NGS kind of the test.
Okay, so now it's not restricted to only stage 4, these tests of targeted
Yeah, to
therapy.
a certain extent, it stage 3 also.
Okay, okay. So I think that's the other thing, right? Again, for years, the feeling was that if you're diagnosed at stage 4, and which is what would happen typically for lung cancer, the feeling was that lung cancer is not treatable. People will, the survival rates are very low. What is the scenario now, Dr. Somani?
So I will say that's again myth now. The outcome of these stage 4 patients, whether they are actionable mutation positive or negative, is more than what is the outcome of the congestive heart failure patient. And usually we talk now about that they have the 60-70% chance of responding to the treatment. Most of the patients, they do survive if they are able to take the drugs based on the NGS mutation detection or combination of the immunotherapy with or without chemotherapy. So these are the definite improvements in the outcome. And we often now talk for these patients that their chances of surviving beyond 2 years is quite high. That's an
Right.
important steps has been achieved.
Right. And that's for both squamous and adenocarcinoma, or it's typically for adenocarcinoma?
So adenocarcinoma, yes, actionable mutation detection is very high, especially in the Asian or the Indian population. For squamous cell cancer, actionable mutations by and large are not there, except the few like ALK or maybe BRAF or something like that. But application of the immunotherapy drugs along with the chemotherapy has given the tremendous improvement in the outcome.
Right. Okay. And the other thing that often happens is when two patients talk to each other, they kind of are often surprised if the two treatments are not the same, right? So they will say, but I went through this, and how come you are going through something else? So, do all lung cancers have the same treatment?
So our treatment philosophy is largely being supported by what pathologists like Dr. Vidya gives us the reports. Like small cell, we have the chemotherapy plus minus immunotherapy. For non-small cell, we typically divide them in the squamous versus non-squamous or adenocarcinoma patient. Then we do the NGS and the PDL1 test to find out actionable mutation are there or not. Various actionable mutations like the EGFR, ALK, ROS1, MET RED, HER, BRAF, and so on are there. So each and every mutations have the different kinds of the drugs. And these drugs are again the first generation, second generation, third generation. So the first thing is that the patient, when they talk each other or come across to each other, they should not have that strange feeling or the feeling like surprise that I'm getting the A drug, you are getting the B drug. No, based on the certain discussion, the patient had been prescribed by the individual doctor that yes, if you can afford like this, we will probably giving you the drugs like the first generation. Maybe that if you can have the best drugs available in the market as on today, maybe the outcome may be a little bit better. So we need to understand what is the difference in the outcome, how the treatment will be sequentially placed after the progression or at the time of the intolerance. So that need to be understood, and then we will be able to find out what is the reason for this differences in the various prescriptions.
Right,
Yeah.
right.
Can I add a point
Sure,
here?
sure. Please.
Lung cancer is called the poster boy for tailor-made or precision therapeutics. All right. So this
Mm,
is though for breast cancer we did have HER2/neu, and patient who expresses HER2/neu was given the anti-Herceptin drug. So then came in lung cancer, and it came in big time. So it is tailor-made treatment. So it is based on how the genes of each and every patient is going to behave. Like one patient A may have EGFR mutation, patient B may not have EGFR mutation. So when they compare, now patient A has been given tyrosine kinase inhibitors because they have EGFR mutations. So that is how it is going to be in lung cancer, and that is how it has been over the last few years. So,
right.
so this is what we call as tailor-made therapeutics. So for each person, how their genes behave, what are the targeted mutations, Dr. Somani said about so many mutations. All right. So we almost now, it is like most of our medical oncologists these days ask for more than 13 gene panel or 12 gene panel. So they
Mm,
do not know how each one is going to behave. And
right.
in a country like India, most of the cases are advanced cancer
Mm,
stages that we see, lung cancers. So here we need to give the benefit of doubt and test as many genes as possible to see if there is possibility of any targeted therapy being given out to these patients. And hence, each patient, it is going to differ, and it is going to be customized for each patient. That is what I would want to say here.
mm. So can you kind of unpack that for a layperson, right? We see these terms like precision medicine, we see these terms like personalized medicine. What does that actually mean, right? So sometimes people will say, okay, immunotherapy is personalized medicine, but targeted therapy is not. So if you can just explain what that means and what, as a layperson, they should understand.
See, when we say precision medicine, it's giving precise drugs for that particular mutation to that particular patient. So
Hmm,
that is how it is driven. So if there are no mutations for that particular patient, they will not be giving these drugs, because we know that these drugs are not only expensive, they have various other side effects. So
right.
earlier, it used to be okay, now we are going to give this regimen to all our patients, but no
Hmm,
more is it. So
hmm,
it is for each patient. Now, when we diagnose generally NSCLC, no, non-small cell lung cancer, and then we tell the patient, look here, you have to go undergo genetic test or NGS test. So I would break it up. I would call NGS as just a genetic test for the layman. So we
hmm,
are testing a large number of gene panels here to see if they have any driver or targetable mutations. So now the therapeutics has improved so much that if there is a particular mutation in a particular gene at a particular locus, the drug is given to that particular area. So, and that is going to inhibit the cell proliferation, and it is going to cause tumor death. So that is what is precision diagnostics and therapeutics is about. When we come to immunotherapy, here we are. This is has come into advancement over the last few years. I would say somewhere about 2015 onwards. And
hmm,
here we are looking at where we are not using chemotherapy. Chemotherapy is very toxic. Here we are trying to use the patient's immune cells to target the tumor cells, which are going to be killed by the patient's immune cells themselves. So that is how these drugs are going to help. And we have something called as PDL1 testing that we do for all our lung cancer cases. Sometimes Even in early stage cancers, we are doing the PD-L1 testing and as well as advanced stages of lung cancer as well. So here, based on what is the threshold cutoff or the percentage that the pathologist is going to give, the medical oncologist is going to decide whether this patient is beneficial for a monotherapy by immune therapy or whether it is going to be a second line of treatment. So these thresholds are important, and we do run a lot of validation and verification in our labs, and we have very good clones given by various companies. So these are called as also companion diagnostics. If we are going to perform a particular, say that our medical oncologist is going to say, I want to give this particular drug to this lung cancer patient, then we do a test on a clone for that particular drug, for that particular patient. So that is how it is driven, and these are called as companion diagnostics. They're very precise and accurate results. And these treatments, believe me, are not really cheap. They are expensive. And when it comes to advocating these tests to the patients, we have to be doubly sure that what result we are releasing in the lab is correct or not. So based on this, immune therapy is given to the patient.
Right. Thank you. Thank you. So one of the things that we also hear is, I have no family history of lung cancer. So I am safe, or, why me, right? So, Dr. Somani, anything on that?
Yeah, that's true that by and large, it's not a familial disease. So it's more related to the environmental factor like smoking, asbestos, other exposure to the other carcinogens or the cancer causing factors, or as we just discussed, like the pollution or the urban environment. So these are the factors. So it is not like the prostate cancer or colon cancer or for that matter breast cancer,
Breast
that
cancer.
where approximately 10% of the patients they have the family history. So lung cancer they don't have it, but still we have seen the patient where the father and then in the due course the son also got the cancer, unfortunately because of the same reason, that is smoking.
Smoking.
So smoking itself becomes a familial history factor.
Right.
That
Right.
both or
So
the
it's the
large
common
number,
environmental
yeah,
factor
common
that.
environment, and they all are. It's a socially acceptable, whether it's
Right.
the grandfather, whether it's the grandson, even the women in the family, they are smoking. They do smoke in a group, something like
Mm.
that.
Mm.
So that
Mm.
itself becomes a familial risk factor. But yes, definitely, family history per se has the very, very low role to play in the development of the lung cancer.
Right. Right. Another thing that often confuses people, we've seen people reach out and say that, you know, my wife was diagnosed with cancer in the lung first, but then the doctor called it, say, metastatic breast cancer, right? So, again, can you explain that so that people understand that, what is actually, because I think people don't understand metastasis is.
In general, when the cancer spreads to the stage 4, usually it goes to the certain parts of the body. Now, for
Mm,
understanding, easy to remember, the parts which are most being affected are the brain, lungs, and the liver and the bones. These are
mm,
the four parts which are being affected by the different cancers. So sometimes the symptoms where the cancer is landing or spreading is the predominant symptoms, or maybe the presentation also, like
mm,
patient present with the seizures or with the um, stroke, or they present with the jaundice because of the liver metastasis, or
correct.
breathlessness because of the lung spread. So
Right.
the first impression goes that it is the lung cancer.
Mm,
But when we investigate, we do the biopsy in the immunohistochemistry test on the biopsy. And when we do the advanced test like the CT, MRI, or the PET CT scan for that matter, then we know. And of course, by our clinical examination, that this patient primarily has the breast cancer and it has gone to the various parts of the body, maybe liver, maybe the bones, and maybe including lung also. So always it is not there that it is the primary only. And many cancers, when they are treated successfully after certain times, they have the presentation as the metastatic or secondary, and often the liver and lungs are the primary organs being affected by that.
right. Thank you. And Dr. Vidya, on that, when people say that based on the, again, they don't kind of understand. So if you can talk about from a radiology perspective, how does are the cells of breast different from lung, etc.? So, are the cancer cells different? How do you determine that
Yeah.
this is, yeah?
So when we get biopsies of lung cancer, the first thing that we do is we look at radiology reports. We see how big is the tumor, whether it is multiple. Generally, multiple tumors or typical cannonball appearance, what we say is indicative of metastatic breast cancer, metastatic cancer from any other part. But whereas it is primary lung cancer, so this is where it is generally one single large tumor that comes up. And when the biopsy is done, we are very cautious because we have to preserve a lot of this tissue for ending up the immunohistochemistry markers. So we see the radiology once we are convinced that the clinical examination, either the PET CT or the CT scan, reveals only a primary lung cancer. We, as far as possible, do not do the immunohistochemistry. But
Right,
otherwise, when we see these adenocarcinomas, many of them look similar under the microscope. So that is where we use something called as immunohistochemistry. And when we know that a patient already is a known case of breast cancer, it becomes our duty first to rule out.
right,
Generally, people having two primary cancers is rare. So
there,
we always think of metastasis first over the primary. So that
right,
is when we use breast specific markers on the lung and see whether it is actually breast cancer that is there or it is lung cancer. We do come across these days, we are seeing those instances where two primary
two
cancers are
primaries,
there in
right.
patients, but still, yes. So morphology may alone not be many times sufficient. We will have to take.
Sorry, I think you've muted yourself.
Yeah. So in this instance, also in this example that you told, the patient, the oncologist would not have given the report of a metastatic breast cancer without the pathology report coming in that manner.
Right, right,
So we use breast specific markers, and if the breast specific markers are positive in the lung cancer, that is when we declare, okay, this is metastasis from the breast, and this is not primary of the lung. So we
right,
can see that even there are instances of sarcomas metastasizing to the lung. We can see a lot of endometrial cancers, etc., which can metastasize to the lung. And the other way is also common, where we see a lot of lung cancer going to the brain. So brain metastasis
right,
does happen. So distant
right,
metastasis of lung cancer itself can occur. In fact, I had a case scenario where I had something going to the stomach as well. So the lung cancer metastasizing to the stomach. So you will not know. Morphology sometimes will be difficult for us under the microscope, and then that is when we take the aid of immunohistochemistry, which is an advanced method of diagnosing and being precise. Okay, this is now lung cancer and not metastasis. But we do not do
right,
it for all our cases. It may be so for about 20% of our cases. And these days, we are also landing up with scenarios of this large cell lung carcinoma, which may not stain for the lung specific immunohistochemistry markers. So these are cases where, exceptional cases where we need to be very precise with our diagnosis. Thank you.
right. Thanks, thanks. So I think, we've talked a lot of some of the common myths or some of the common understanding, and both of you have addressed this. Is there any kind of strange perception that you've come across that you want to make sure that you address with our audience, Dr. Somani? I'm sure
So,
you've got a few, but if there's
yeah, no,
anything that kind of
only
strikes.
thing which I will appeal to the all those who are listening and seeing us, that please stop smoking. There is no use; it's only misuse, and there is no concept like less smoking or more smoking. Uh, for the health of yourself, for your family, and for the health of the nation, stop smoking in all ways.
Right. Dr. Vidya?
Yeah, a couple of points here. One is, like Dr. Somani said, stop smoking. I really do not know what is going to be the side effects of vaping in future.
Hmm.
So the more you're going to reject these kind of things and try to have your self motivation and be determined to stop smoking instead of adopting to other mechanisms which can again cause addiction in one way
Correct.
or the other. It is better to be away even from vaping. That is what I would suggest. And the third thing is, when you come into the hospital for a diagnosis to happen, please listen to your physician, your pulmonologist, your radiologist, your medical oncologist, and your pathologist, because we do not advise tests unnecessarily. We are here to give the benefit of doubt on what we are diagnosing as being accurate. And I do see that in resource low resource settings,
Low resource.
when patients are told like you have to get these additional tests, we are doing this for a reason, for a benefit to the patient here. And like Dr. Somani mentioned, yes, NGS is the way forward for lung cancer treatment. So this has to be it has to be got done by every patient whose biopsy has a diagnosis of an adeno or a squamous cell carcinoma. I see many patients losing their time in running between hospital to hospital, institute to institute. So I don't think this is going to be beneficial to them. They're going to, in fact, lose time. Instead, get the diagnosis done at the right time, and also get the treatment done at the correct time and correct place. Thank you.
Right. No, I think very valid points, both Dr. Somani and Dr. Vidya. I think this is something that it's very important for people to understand. That's why we are doing this, that people understand the role of these tests, because, it's not just, I mean, they can't just believe that, because you're going into a hospital, they will prescribe a battery of tests. There is a reason for these tests, and they determine the course of treatment and the treatment efficiency as well, right? So thank you both for answering those questions and, taking time, Dr. Somani and Dr. Vidya. Very much appreciative of the time you've spent answering each of these questions in great detail. And thank you to Roche for supporting this awareness initiative. And to our audience, if you still have any questions, do write into us and we will, address those questions. If not right there, then in the next session. So thank you so much, everybody.
Thanks for this opportunity. Thank